Um, okay. So, um, honestly, the reason I thought about like kidneys is because I was thinking about some of the problems with geriatric patients, like when we're thinking about the final or just thinking about like health in general, is that kidneys help with excreting drugs. And when the kidneys aren't really doing their job, we can excrete drugs efficiently and they can become toxic. That's why with those older patients, liver and renal problems are pretty much contraindications for every medication because the kidneys and the liver are so important for drug metabolism, the liver, and then drug excretion for the kidneys. So I think in terms of what the kidneys do, does anybody remember like really important things that our kidneys do to help our body besides excreting drugs?
It filtrates electrolytes, sodium and
Mhm.
potassium.
Yeah.
Doesn't it also like clean out our blood? And that's why like when you have kidney failure, people will go into dialysis.
Because things get into the blood that are not supposed to. What else? Well, the kidneys, besides those, um, if you remember ACE inhibitors, our like enalapril, lisinopril, or our ARBs like losartan, atorvastatin, or renin inhibitors like alicaserin, all of those work in the kidneys and they're blood pressure medications, right? So the kidneys play a role in regulating blood pressure. And they do that by releasing something called renin. Because if you remember the RAS system, renin gets released, which then helps angiotensin 1,
Yeah.
eventually then converts to angiotensin 2, and right? And that's where we get our ACE. And then our ARBs also prevent the angiotensin from converting because they're angiotensin receptor blockers. So the kidneys play an important role in blood pressure. So that's where our ARBs and ACEs come in. And they also increase red blood cell production by secreting something called erythropoietin. Does anybody know what erythropoietin is?
Producing of red blood cells?
Not reducing, they actually
No,
help
producing.
form. Oh, I
Producing.
thought you said reducing. I was like,
Oh,
no, 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 definitely not
producing.
reducing. No, yes, producing. Yeah, my bad. That maybe it was my headphones that but yeah, so they help produce red blood cells. So in summary, electrolytes, they help regulate fluid. If we regulate fluid, we regulate blood pressure. It does that through renin. We also have an important role with red blood cell production with erythropoietin. This is where A and P becomes important again. I'm not going to get too much into the different structures in the kidney, but we have the kidneys, the uterus, the bladder, the urethra. All of that helps with getting everything down and out of the body. Now, as we said, for older patients, right, there are older adults, they have changes in these. So they have decreased blood flow, decreased glomerular filtration rate, or that rate that helps us filter all of those products and those electrolytes. And we have a decreased drug clearance, which means we have increased drug to drug interactions. Okay. So that's just the kidneys. Those are the functions. That's what it does. Now, diagnostic studies are one of the most important things for the kidneys because they tell us a lot of things about the kidneys. So, can anyone tell me and this is one of those geriatric questions for the final, what are abnormal findings in a urine analysis?
Albumin, secreted albumin in the urine is an abnormal. Oh,
Mm-hmm.
creatinine.
Bacteria.
Yeah. What else?
Because you're not supposed to be excreting protein in your urine, so that's a sign of kidney failure already. Kidney failure, yeah.
Yeah. So no protein, no bacteria. What else? What else shouldn't be in our blood? I mean, our urine. I think
Well,
I said that
blood.
wrong. Yeah. What shouldn't be in the
Glucose.
urine? Yes, sugar, right? And diabetics, that's why they get polyuria, because all that sugar comes out, and that's why we see that in the urine. So problems, we just named them all, right? No sugar, no protein, no creatinine, no blood, no bacteria. We don't want to see any of that in our urine analysis. Okay. And so also another way of saying, how do we know if bacteria is in there? Positive nitrates is a way of saying that we have bacteria or something in our urine, which can indicate a UTI. So then we also have renal function test, right? And what is urine specific gravity and what's the normal range?
One 1.005 to 1.0015.
Close. It's like 1.005 to like 1.030, around there, okay?
Okay.
So that's urine specific gravity. And what that tells us is that if it's really, really low, right, that means that our urine is very diluted. But if it's really, really high, that means our urine is very concentrated. And that's why with patients who have kidney failure or chronic kidney disease have a high urine specific gravity, because they're not peeing as much, and whatever comes out, a lot of stuff comes out in that little bit. That's why it's highly concentrated. And yeah, so that's the most important thing. That's why, I wanted to mention that, because that's an important lab value. And something else that's really important is a 24-hour creatinine clearance. And we use that to actually measure our kidney function, because as someone mentioned, creatinine should not be in our urine. If it is, that's a problem, okay? And when we do a 24-hour urine collection, we must discard the first urine voided and then collect the rest. Why? Because sometimes that first urine might not give us what we need. The second urine will be more accurate, okay? And basically, it's collected over 24 hours because a lot of things happen in a day based on what you eat, things like that. So it's collected over a 24-hour period. But this is a way to measure kidney function. Now, creatinine, like I said, it measures the effectiveness of renal function, and it's a product of muscle, right? Muscle breakdown, muscle energy metabolism creates creatinine, okay? And normal in men is 0.6 to 1.12, and for females, it's 0.4 to 1.0. Now, BUN is also a way to look at our kidney function, but it's also a product of protein metabolism. So we look at this BUN creatinine ratio to see their hydration status. What is it, okay? If it's elevated, we see that in hypovolemia, when they don't have enough volume or they're dehydrated, which makes sense, right? If a person is dehydrated, right, they're not really peeing as much. They're keeping a lot in, which means that BUN and creatinine, instead of going out in the urine, comes into their blood and into their body. So that's why we expect it to be higher. Now, CT or CAT scans and MRIs are really important. Does anybody remember a drug that is very bad when it comes to having any sort of contrast related diagnostic procedure?
What is that again?
A drug that if you take it with IV contrast, it can damage the kidneys. So that drug is metformin. Metformin is a diabetic drug, or a biguanide. It's a part of that class, which is an insulin sensitizer. And it can cause things like hypoglycemia, right? Because it's a hypoglycemic agent, especially if it's combined with other hypoglycemics. But the most important thing about metformin is that if you give it with a patient who's going in for IV contrast, the drug itself is not necessarily toxic to your kidneys, but in combination with the IV contrast, the medication builds up and it can cause nephrotoxicity. So we always want to warn our patients that with metformin, they must stop it within 48 hours of a contrast procedure. Now, also, MRIs is another procedure where we shouldn't have certain things in the room. What are some things that we're not allowed to have in the room if someone's going to go into an MRI?
Any
Like
metals?
metals?
Say that again?
Metals?
Metals.
Yes, right? Because those are going to attract and it's not going to be good. So, no credit cards, no metal objects, right? No hearing aids, things like that. It can mess up the MRI as well. Also, no nicotine or nitroglycerin patches because they have a metal backing and it can cause burns if they're not removed, okay? No oxygen tanks, ventilators, stethoscopes, none of that stuff. So, hopefully, that was a good review of what stuff we don't get to bring into those rooms and what medications. Then, if we're going to do an endoscopic procedure, right? If we're going to go in their throat, make sure they're NPO. With biopsies, right? If we're gonna if we're gonna take something out of like a tumor or something, right? What should we tell our patients to look out for? Or what should they not be taking, right? If they're gonna go for a biopsy, what should we be careful for?
They shouldn't be taking no aspirins, anything that's anticoagulants and stuff like that, because they could bleed out.
Yes, so they usually tell them to stop a couple days or a couple like hours, said before a procedure, right? So we want to watch out for that. So nursing interventions when it comes for a biopsy is monitor for bleeding, right? If they have severe pain in the back or the shoulder of the abdomen, that can indicate bleeding, especially if it's a kidney biopsy based on that location. Look at the puncture site for signs of bleeding, right? If it's like that frank red blood, we know they're actively bleeding right now, but if it's like dark and dry, not really. We want to look at vital signs, maintain bed rest, and always make sure we have an IV line in case something happens. I'm not going to get into the other stuff because I don't really know it that well, and I'm not going to teach something I don't know too much about. But we have a lot of important vocabulary, I think, when it comes to the kidneys and changes in urine output. We have anuria, which is a total urine output of less than 50 in 24 hours. And what is normal urine output?
30 mLs per hour.
Yes. So oliguria can be less than 30 ml per hour or less than 500 ml in 24 hours. Dysuria is painful or difficult urination. Polyuria, too much urination. Nocturia, right, peeing at night. Urine frequency, they're going a lot. Urinary hesitancy, can't really go. Urinary retention, they also can't really go. And yeah, those are just important terms that we have for the kidneys. And there's a lot of them. So it's good to understand the difference between them because they might use that term and they're not going to say that it means too much urination or painful urination. They might just say oliguria, and we have to understand what that means. So we talked about urine, what shouldn't be in urine, right? So colors of urine are also really important. So pale urine is like diluted, or they might have alcohol consumption or diabetes insipidus. Yellow, so milky white means infection. So that's not good. Bright yellow means that you're taking too much vitamins. Dark amber to orange, concentrated dehydration. Orange urine means they're dehydrated. Pink to red, we're thinking blood, right? If we see a reddish, pinkish tint in urine, we're thinking blood, medications, or maybe they took medications like phenytoin, okay? Blue or green, usually in certain medications as well, or dyes like methyl blue. Aniprilene, one of those TCAs, right? Those tricyclic antidepressants can cause blue or green urination. Dark brown or black means like really old red blood cells, which is really not good. This is like extreme cases of dehydration. So I just want to go over the different colors of urine so we know. Once again, what would also be some characteristics of urine that would make us say, hey, this is not normal?
Blood in the urine?
Right? If we see something like that. What about an odor? Should it smell like something foul?
No.
No, right? So we don't want that, right? And like I said, other stuff relates to the urine analysis when we're talking about, right, no protein, no bacteria, no sugar, no blood. We don't want to see any of that in a urine analysis. And a urine culture is when we're looking into the bacteria that could be in the urine. Now, things that we might see, like bladder pain or flank pain, might be signs of a kidney problem, right? Or like a UTI or things like that. So we just have to be very careful. And the overall is that we want to teach them about procedures. We want to teach them about, issues with the kidneys or urinary symptoms that they might see, like problems in their urine, things that might be normal with medications versus abnormal, right? Interventions, right? Depending on the type of problem, we might want to encourage fluid intake, or it might be contraindicated if they have something like hypervolemia in relation to something, right? So there's different things that we're going to want to teach them. We might want to give them analgesics if they have flank pain or if they have something like UTI. We also want to look at voiding patterns, the characteristic color, the odors, all of that stuff. Now, some people already mentioned renal failure. We mentioned all these things, and we have some kidney disorders, okay? And remember, I like to think about med-surg questions or any sort of like question that comes to a disease based on what the disease is, right? If I have a cardiac issue, there may be a respiratory issue like in heart failure if it's left-sided, but in kidneys, I don't have as much of a cardiac issue. Blood pressure, yes, but airway is not going to be my priority for someone who has chronic kidney disorder unless they have some other comorbidity, because kidney disorders specifically aren't going to necessarily affect the heart, the respiratory rate or things like that. Same thing with cardiac. It's not going to be too much into it. It can progress to that maybe in the future, but beginning signs, I'm thinking more or less, okay, I would pick a priority as looking at fluid and electrolytes, right? Looking at their INOs, looking at their electrolyte imbalances, because those are commonly experienced things in the kidneys that should be prioritized. You know what I mean? It's like looking at the symptoms, looking at where it's working, because I notice, like when you take tests, that if this disorder doesn't necessarily cause respiratory problems, I'm not going to look at the answer as respiratory, even though I know ABCs. So patients with kidney disorders commonly experience fluid and electrolyte imbalances, and they require careful assessment. So priorities with kidney disorder patients are INOs, right? Monitoring tools, looking at those electrolytes, making sure they're keeping a dietary intake of what they're eating every day, right? Seeing if they're keeping any edema, and retaining any fluid, right? How much urine are they excreting? Are they excreting any? What color is it? And other sorts of fluid loss. Are they vomiting? Things like that, right? But the most accurate indicator of fluid loss or gain is weight, right? How we know if somebody's retaining fluid with edema, right? If they gain 3 or more pounds in a day or two, we know they're having fluid buildup. If they lose 3 pounds in a day, they're losing fluid. So those are issues, and that's why weight is so important, especially in kidney disorders. So renal failure can also cause metabolic acidosis. So does anybody remember what metabolic acidosis is?
Mm-mm. Oh, my mic was on. Hi. The buildup of acid due to like kidney disease or kidney failure.
Yes. Does anybody remember like what the pH value would be and what that bicarbonate value might be?
pH would be below 7.35.
Mm-hmm.
And what was the other one you asked?
Bicarbonate.
That one I don't remember.
It's okay. So with metabolic, like acidosis or alkalosis, the values that we're looking at is the pH and the bicarbonate, right? Because in metabolic alkalosis, pH is high, bicarbonate's high. In metabolic acidosis, pH is low, bicarbonate's low. So normal bicarbonate is 22 to 26. Normal blood pH is 7.35 to 7.45. So in renal failure, they have a decreased pH of less than 7.35, and they have a decreased bicarbonate level or less than 22, which is really important because that means their blood is becoming very acidic based on the things that they're retaining. That's because of all of those increased potassium, increased sodium, right? All of these things that are coming into their blood. And things that we might also see is decreased calcium and increased phosphorus. Remember, calcium and phosphorus have an inverse relationship. So when one's high, the other one's low. So also lab values that we'll see is increased BUN and creatinine. As we mentioned already, but creatinine is an indicator of kidney effectiveness, and so is BUN. So they're both going to be increased. And remember, when you're in metabolic acidosis, you compensate with respiratory alkalosis, which is that high pH and of greater than 7.45 and a low CO2 of less than 35 to 45 normal, so it's less than 35 because they're hyperventilating, right? Because imagine if you have a really acidic pH, right? You want to compensate by increasing that pH level to counteract that. But because of that, your CO2 is going to drop because you're hyperventilating. Okay, so all that's going to help reduce the acidity and make a more alkaline environment by hyperventilating. So we expect to see potentially someone who has renal failure and goes into metabolic acidosis will compensate with respiratory alkalosis and have hyperventilation. Okay, so the next thing that we have is acute kidney injury. So acute kidney injury is this rapid loss of renal function due to damage of the kidneys that is reversible. Okay, so this is something that happens, right? Maybe they had an accident, right? Maybe they experienced burns. Maybe something happens, right? And the kidneys got injured somehow in some way, but it's reversible. So if we can take interventions right away, we can help them. And it results in a decreased GFR or glomerular filtration rate and oliguria, which is urine output less than 30 ml. And it's manifested by a sharp decrease in urine output. So if all of a sudden, you know, our patient just, maybe they were peeing 60, 50 ml every hour, and now all of a sudden they're only peeing 10 ml, that's an indication of acute kidney injury. Now, things that we might also see is that, right, the serum creatinine is going to be above because that indicates kidney injury or kidney failure. Hypovolemia, okay, they're going to have like fluid volume deficit, and that's because, right, they're not really being able to regulate everything that's going through their body, so they're just going to have lower fluid volume. They're not going to really be able to be good at managing their fluid level. So it's not going to go up because they're not really able to retain fluid either. They're going to be hypotensive because the vessels are going to dilate, right? They're going to have a decreased cardiac output, which could lead to heart failure. They could have obstruction of the kidneys or, right, like if there's a blockage or a kidney stone that can block, that could even also cause, in a way, a kidney injury. And if there's maybe even an obstruction of the renal arteries or the veins, that can also potentially cause a kidney injury, right? So hypovolemia, hypotension can be, you know, manifestations of acute kidney injury, but they could also cause acute kidney injury, okay? So the pre-renal phase is, there's a couple little phases. So we have pre-renal, intrarenal, and post-renal. So pre-renal is like this very early stage. So we have a decreased blood flow, we get dehydrated, they can go into shock, hypotension, potentially heart failure, and hemorrhage. That's because the blood flow is decreasing. If the blood flow is decreasing, they can become dehydrated. They can go into shock. The decreased blood flow means it's dilated, those arteries, so they're going to have hypotension, and they could be hemorrhaging. Intrarenal now is not, so pre-renal is caused by decreased blood flow. Something obstructs the blood flow, and it can lead to things like dehydration, shock, hypotension, heart failure, hemorrhage. Intrarenal means that there's damage to the kidneys, so it's a little bit more severe than pre-renal. And this includes, you'll see increased BUN now, increased creatinine, low specific gravity, and increased urine sodium. Why? Because the low specific gravity is that now they might be having a problem with going to the bathroom, and low urine specific gravity means that the urine is not as concentrated, okay? So this can be due to nephrotic syndrome, polycystic kidney disease, glomerulonephritis, because these are damaging symptoms to the kidneys. And then we have acute tubular necrosis, or AKI, which is when there's a damage to those kidney tubules, and that's usually due to toxic drugs or prolonged ischemia or prolonged reduced blood flow, okay? So when we have intrarenal, we're thinking about something that causes damage to the kidneys, okay? And it's causing increased blood and creatinine, because remember, everything's getting stuck in the blood now because it can't get filtered out. So anything that comes out of the urine is going to start to be a little low in concentrated stuff because it's going in the body. So I like to think of, right, pre-renal means decreased blood flow. So think of anything that can cause decreased blood flow: dehydration, shock, hypotension, heart failure, hemorrhage, all causes a decrease in blood flow. Intrarenal, let's think about anything that can cause damage to the kidneys, right? Nephrotoxic drugs or acute tubular necrosis, something's happening to the tubes of the kidneys, glomerulonephritis or inflammation of the glomeruli, right? Polycystic kidney disease, nephrotic syndrome, all of these cause damage to the kidneys, which cause that increased blood, creatinine, and low specific gravity of the urine, which is our intrarenal stage. We also have postrenal, which means this causes obstruction to urine flow, right? Benign prostate hyperplasia, right? The idea of the prostate getting so enlarged that it blocks that urine output. That's how urine output gets obstructed. Kidney stones block obstruction, and infection can block urine output, right? So that's how we're going to think about these stages. Pre-renal, what are things that can cause decreased blood flow? Intrarenal, what sorts of diseases can cause damage to the kidneys? Post-renal, what can obstruct my urine outflow? Any questions?
Questions, or do you want us to answer?
No, I didn't know if you had any questions. I didn't want to move on if like anybody was confused.
Oh, no questions so far.
Okay. So, the next thing that we can get into is there's different phases, okay? When we have an acute kidney injury, we have phases. So like I said, these are categories, different things that could happen that can cause acute kidney injury. So it could be pre-renal causes, intrarenal, or post-renal. Then we have phases, meaning what happens in acute kidney injury, right? These stages of it, like what are the manifestations? So the categories were like the causes of it, 3 different causes. This is the phases or the manifestations. So one of that is initiation, right? So something happens, acute kidney injury. Okay. The first thing that we're going to see is oliguria, which lasts 1 to 2 weeks. Like I said, we have a urine output less than 4 to 500 in 24 hours. We have a increased urine specific gravity. Why? Because the urine, you're not peeing out much. So it's very, very concentrated, whatever comes out. We get edema from hypervolemia, because if we're retaining all of that electrolytes, all of that stuff that should be coming out, we're going to have fluid gain, okay? We're also going to see elevated bun, creatinine, and potassium, and even potentially metabolic acidosis, as well as heart failure, okay? This could be some of those really first manifestations that we see. So a key indication, like we said, a decrease or a drop in urine output that keys us in that they have acute kidney injury. So oliguria, that first phase of 1 to 3 weeks, and that's where we're seeing the sudden onset and a drop in urine output that can also cause edema from the hypervolemia of all of that stuff for keeping in the body, increase urine specific gravity. They can even go into metabolic acidosis. The next stage is after they get out of oliguria, the kidneys figure out a way to fix themselves and they go into diuresis. So now they pee again. Okay, this means that, hey, the glomerular filtration or the GFR is starting to work again. So they're peeing out, but now we got to not watch out for hypervolemia, but hypo, because they might pee out too much because the kidneys are trying to regulate themselves. So the urine output's going to really increase of diuresis up to 4,000 to 5,000 milliliters a day. Okay, this is a good sign, but they're going to have a decreased urine specific gravity because that urine's super concentrated from everything that's being peed out. They might also have hypotension and fluid and electrolyte imbalances because they're peeing out too much. And then we get into recovery, which is the last phase. Remember, acute kidney injury is reversible. So this is where the kidneys improve, may take 3 to 12 months. lab values like the bun, creatinine, electrolytes, everything goes back to normal. This is great. Now, something that we see is, as we said, in that diuresis phase, a problem is that we pee out too much and we could potentially have, hyperkalemia, which is very life-threatening. And does anybody remember the EKG problem that we might see in hyperkalemia? What it could do to it? It can cause a tall peaked T wave, right? So hypokalemia causes an inverted T wave, whereas hyperkalemia causes a peaked T wave. So we really want to watch out and monitor the EKGs with these patients. Symptoms of hyperkalemia include irritability, abdominal cramps, diarrhea, parasynesthesia, and generalized muscle weakness. For me, I think the most important ones to remember in this scenario are the abdominal cramps, the parasynesthesia, the numbness, the muscle weakness besides those EKG changes. Okay, so now that we know the problem with potassium is that it can cause cardiac problems, really, really bad. Does anybody remember the different medications that we can give to treat hyperkalemia? I'll give you a hint. One of them makes you go to the bathroom.
Furosemide?
Yeah, we can give furosemide for hyperkalemia to treat it. There's other ones too. Does anybody remember the one that makes you poop? So there's Kexalate, which is basically a medication that treats hyperkalemia by making you poop out the potassium. Okay, so we really got to watch out for bowel movements. We could also give them 10 units of regular insulin because the insulin can actually help get those potassium back into the cells. That's how we could use the insulin in terms of managing high potassium levels. We could also use 1 gram of calcium gluconate to shift potassium back into the cell. We can give 50% dextrose IV, or we can give 1 unit of albuterol nebulizer. All of these can help with hyperkalemia. But yes, also furosemide, right? But we will have to be careful because they might not be suggested for someone who has acute kidney injury, because if they're in that diuresis phase and they're getting hyperkalemia, they're going to be peeing way too much. So it might not be the drug of choice, but it is a drug used to treat hyperkalemia normally. But in terms of acute kidney injury, you might go with things like Kexalate with bowel movements, insulin, calcium gluconate, 50% dextrose, or 1 unit of albuterol nebulizer. Now, interventions. We have to think about it. Acute kidney injury has 3 categories: pre-renal, intra-renal, post-renal. We want to eliminate the cause. Is it pre-renal? Is it a decrease in blood flow? Let's increase blood flow. Is it intra-renal? Is it a sort of kidney disease? Let's fix that. Let's see if we could treat the disease. Is it post-renal? Is it an obstruction to blood to urine output? So let's figure out how we could fix urine output. And does anybody remember any sorts of drugs that are used to treat BPH? Well, examples include prazosin or tamsulosin or simuzosin, because those drugs are a part of those alpha blockers. So when they block the alpha receptors, right, because alpha normally is sympathetic stimulation, which means you're not going to need to go to the bathroom if you're running from someone. But if you block them, they actually help your urge to pee. So prazosin, tamsulosin are some of those drugs that we can give for PPH, which can actually help with the post-renal stage of acute kidney injury. But other things, right? If it's metabolic acidosis, hyperkalemia, hyperphosphatemia, hypocalcemia, right? If it's an electrolyte problem, let's fix the electrolyte problem. Is it metabolic acidosis? Let's fix metabolic acidosis, right? If they're in the oliguric phase, we want them to have low protein, a high carbohydrate diet, and restricted potassium intake. Because think about it, right? If they're in that oliguric phase, right, and we're talking about edema with the hypervolemia and things like that, increased bun, increased creatinine, and metabolic acidosis. Metabolic acidosis can cause the risk of high potassium levels. So we don't want potassium and we don't want protein because we don't want that coming out in the urine. And high carbohydrate would be good for their nutrition, right? Diuresis, low protein, high caloric diet, and restricted fluid intake because we want them to drink, but not drink too much because they're going to pee out a lot too, okay? So we're going to have to watch their fluid intake. And remember, these are kidney problems. So, right, daily weights, INOs, okay? Monitoring those electrolytes. That's the things that we're looking out for. Maybe dialysis, because this is not a cardiac or a respiratory problem. So those are not going to be a part of our priority interventions. It's daily weights to see what's going on with them, their INOs, and their electrolytes. Priorities with these patients. Now, chronic kidney disease is a little different. So this just means any sort of term. It's a term just describes kidney damage or a decrease in glomerular filtration rate lasting for 3 months or more. Main causes are hypertension and diabetes mellitus. Because remember, diabetes can cause nephropathy or damage to the kidneys. Okay, so we could also have azotemia, which is elevated BUN, which increases the risk of seizures. And this is irreversible. If they're in chronic kidney disease, it's irreversible compared to acute kidney injury, which is reversible. Now, these patients can also have oliguria because, right, if the kidneys aren't functioning properly, they're not going to really be peeing out much, which means they have increased potassium, increased BUN, increased creatinine, decreased calcium, increased phosphorus. Remember, calcium and phosphorus, inverse relationship, increase urine-specific gravity because anything that comes out of their urine is going to be super concentrated. Now, signs that we might see is a gray bronze skin color, flaky skin because they might be, they have all this buildup in their body, okay? You might have ecchymosis, purpura, they have like thin, brittle nails, right? Thin hair, tremors, seizures, right? Because remember, these cause electrolyte imbalance, which means it could also cause increased sodium levels. And sodium, whether low or high, our priority is seizures. So we also have the issue of seizures when we have chronic kidney disease or renal failure. So something that we have that can help is calcium acetate, which binds to phosphorus, and decreased phosphorus, which increased calciums, which actually helps correct that electrolyte imbalance that's a part of this chronic kidney disease and helps with managing some of those symptoms. But we have to give this medication with meals. Diet, decreased sodium, right? Decreased potassium, decreased protein. We don't want any of that, okay? Because all of that is already being elevated because of the problems with the increased BUN, increased creatinine, increased potassium, increased sodium. So we don't want to give any of that, okay? We also can have anemia, right? Because remember, one important function of the kidneys is the creation or the production of erythropoietin. So if the kidneys are damaged, red blood cells aren't going to be produced as much, which means we might have anemia, which is fatigue, cyanosis, things like that, okay? So urinemia, anemia, and acidosis are consistent clinical manifestations of chronic renal failure. Now, management. Dry skin, right? So antipyretics, so we could relieve itching. Calcium carbonate, right, to lower phosphate, because if you increase calcium, you decrease phosphorus and vice versa. Loop diuretics, right? Someone mentioned furosemide to help with those potassium levels, right? Also will help them pee, which is the problem. They can't do that here. But we also must have fluid restrictions as well. Vitamins and supplements, right? Because they might have inadequate intake due to the kidneys and all of the problems with metabolism. We might also have antihypertensives to control blood pressure associated with edema, but we're not going to use our ACEs and our ARBs. Why? Because they work in the kidneys. So think about it, right? An antihypertensive that we're not going to give is an ACE inhibitor like enalapril or lisinopril, or ARBs like losartan or torvastatin because they work in the kidneys. So I'm not going to give my patient anything that's going to work in the kidneys when their kidneys aren't really working. That's just not going to make sense. Antiemetics, right? Take before meals to help alleviate nausea and vomiting that you can get with chronic kidney disease. Famotidine, that's something else that we also want to give them, right? To decrease any sort of gastric acid, and docusate to prevent maybe any potential constipation as a result of electrolyte imbalances. Because remember, calcium levels also can cause constipation. So if they're too high as a result of some sort of imbalance, we might need to give them something. Remember, the priority is getting these electrolyte levels down, right? Making sure they're having a diet that's low in these electrolytes so that they don't increase even more. And if we have to give any sort of antihypertensives, because now the blood pressure is out of whack because the kidneys aren't functioning properly, they shouldn't be ACEs or ARBs. Assessment, think about kidneys, fluid status, nutritional status, patient knowledge. What do they know about it, okay? About their kidney problem. What do they know? Activity tolerance might be a problem, and any sort of potential complications. Complications, right? Anemia. Once again, because erythropoietin is decreased RBCs, big problem, okay? We might have bone disease, or vascular calcifications because of that high phosphorus and those low calcium levels. And we're having a problem with vitamin D metabolism because vitamin D helps with calcium. So if calcium has a problem, vitamin D metabolism also has a problem. That's why we might have vitamin disturbances. Hyperkalemia, right? Due to the metabolic acidosis, okay? So no diet from that, no like spirulactone, no potassium sparing diuretics, right? Because we need to lower those potassium levels. Hypertension, because the kidneys aren't working. They normally help lower with that RAS system. So we have a problem with that. We have a malfunction with the renin, angiotensin, aldosterone system. So no ACEs, no ARBs, no renin inhibitors, okay? Give them calcium channel blockers, right? Give them something else, just not these. They might have pericarditis, pericardial effusion, pericardial tamponade. I know we didn't learn about pericardial tamponade, but pericardial tamponade is a worse form of pericardial effusion, which means that they have fluid building up in the pericardial space, or that sac around the heart. And the tamponade is like the more extreme version of pleural effusion if it doesn't get fixed. And that's because we have so much waste products in the body that it can get to the heart. Because remember, like 25 or 30% of the blood flow goes to the kidneys, which means the heart and the kidneys have a very close relationship. Now, goals include, we want to maintain their intakes and outputs, their fluid intake without too much fluid, right? We want to have a good nutritional intake because of the problems with the electrolytes, and really watch sodium, potassium, calcium, phosphorus. Increase their knowledge, especially for chronic kidney disease patients, okay? They might have intolerance to activity, especially with chronic kidney disease, because they can have anemia. All of these problems I'm talking about here are problems with, especially with chronic kidney disease as it worsens, right? Acute kidney injury can cause these temporarily, right? But chronic kidney disease can cause these for long term. Improve self-esteem, right? They might have self-esteem issues because of the symptoms that they're presenting. They might not be able to do things the way they used to. And we want to reduce complications as much as possible. So if we're thinking about interventions, we talk so much about kidneys and the issues with kidneys. What are some interventions that you would prioritize as a nurse if your patient comes in with a kidney disease?
Low sodium diet.
What else?
Monitoring their intake and output and doing daily weights.
Right, because they can have problems with volume retention, as we saw in acute kidney disease. They could have hypovolemia or hypervolemia, right? And chronic kidney can cause, a lot of fluid retention. What else should we watch out for?
Swollen legs because of retaining water.
Right, are they having edema? What else should we look out for?
Blood pressure.
Yes, because kidneys, they're having a problem, and kidneys affect blood pressure. Diet, right? That low protein, high calorie, low sodium, low potassium. Encourage vitamin supplements because they need that, right? Weight changes, INOs. Monitor all those lab values, right? Especially RBCs, right? Because the red blood cells, they can have a complication of anemia. We really want to watch out for any sort of heart problems. So if they show signs of chest pain or pleuritic pain, really bad problem, okay? So we want to also watch out for cardiac symptoms, but not really respiratory, right? So that wouldn't be a priority in these situations. Role changes, right? Now we also just want to look into that, right? Like change that might go on in the family or the household dynamic because of the patient having a kidney problem. Now, those are interventions. Like I said, the diets, lab values, fluid status, all of that. Those are the things that we're trying to really look at with these patients. Now, if they have a problem, the kidneys can't really, do their job, and they go into chronic kidney disease, we can use hemodialysis, okay? So we use this when a patient is acutely ill to help resume function and help with replacement. Usually patients go with this a lot, okay? The objective is to get rid of all of those excess stuff and remove it, okay? So we want to also assess for thrills and I don't know how to say that word. I think it's buries or brutes. I don't know how to say that word, but it's just a cardiac sound that we might hear because that's indicating that there might be some fluid and there might be some problems going on with the hemodialysis, okay? Remember, always with these kidney patients, low protein, high calorie. Now, does anybody remember the problems with fistulas and grafts? What we should not do if they have a fistula or a graft?
For fistulas, I think you don't do your vitals on the arm that the fistula is on.
Yes.
I think.
Yes. You're correct
It's
because it could burst. Yeah, you were so on track. It was great. Yes. The fistula and the graft. Same sort of thing. The fistula graft, no blood pressure and no drawing blood from that arm because it can pop. It is their access to get the dialysis. And if that is broken, they can't get it. So no blood pressure, no vital signs in that area, and no drawing blood from there. Don't even put an IV in there. Leave that arm alone. And just a tip, what I've seen in the hospitals, they should have an identification. There should be something that lets you know that they have a fistula. Okay, they should have something like don't use like a limular, don't use it, okay? Because God forbid you say, okay, my patient has a fistula in the right arm, and you go to do blood pressure without knowing, could be a problem. Now, hemodialysis, like I said, different. We're filtering the blood. Peritoneal dialysis is a little different. We can remove the substances, these toxic substances that build up and reestablish normal fluid and electrolyte balance, but we do it through the peritoneal or like the stomach cavities, okay? If they can't tolerate or they're not willing to go through hemodialysis, they could do peritoneal dialysis, which is they're actually able to do this on their own. They don't have to come to the hospital. So the thing is with that is they have like a catheter and a filtration system, okay? So it's a 7-day-a-week process. It's continuous. If they have like cloudiness appearance, it can indicate peritonitis or an inflammation in the peritoneal cavity. For this, because we're going through the stomach, we actually want to increase protein intake and increase calorie intake. And that's because in this peritoneal dialysis, we can actually lose protein. That's one of the most important things when it comes down to peritoneal dialysis, that they have a loss of protein. And they could also have hypercalcemia and the complication of peritonitis. So we want to increase their protein intake in peritoneal dialysis and caloric intake. And yeah, we also want to advise our clients to wear masks while performing the exchange to prevent any contamination of the catheter and the tubing, okay? And especially if they have like upper respiratory infections. So the main difference between like these two is that with this one, they could do it from home and it's a slower process. And the problems that we could have is peritoneal dialysis and loss of protein compared to hemodialysis, which actually we want low protein intake. So that's a little different in terms of diet, okay? And also where they work. One goes through the blood and the other one goes through the stomach. So generally, when they're on dialysis, we need potent vascular access, okay? Especially for those hemodialysis patients and things like that. We want to search for buries or thrills, right? They need to be evaluated every 8 to 12 hours. Fluid balance, IV therapy, accurate INOs, because these are kidney problems, okay? So we really need to watch out for that. We also want to look out for signs and symptoms of infection, peritonitis, or anything like that, because remember, if they have redness, swelling, or drainage in any of those sites, it could be a huge problem, okay? Cardiac and respiratory status, because, we're doing so much with the blood and exchange, they might have problems with that, okay? And cardiovascular medications should be held prior to dialysis because they can interfere with the dialysis. So no cardiac medications before that. So I think that's the most important point. Other interventions, right? Looking at pain, looking at their diet, right? Their sodium, potassium, protein, nutritional. I think everything's starting to repeat. Skincare, right? Looking at all of that, those signs and symptoms. If they're having, irritations, things like that, especially with the peritoneal, you're doing it through the stomach, or that fistula if they're having, problems with the access. Yeah. And this is just surgery management. This is just regular preoperative, postoperative interventions. Remember, preoperative, we always need to have the informed consent, looking at their eye, nose, their intake, seeing if they have any problems with renal or cardiac dysfunctions. Postoperative, right, assessments, right, any sort of hemorrhages, right, looking at the body systems, the electrolytes, potential hemorrhages, abdominal distension, especially if it's like, there was a problem with peritoneal, dialysis, things like that. Okay. Once again, postoperative interventions relate to generally what you would do postoperative for surgery, signs, symptoms of bleeding, making sure we get them moving as soon as possible. Airway is the priority if it's any surgery. Cough, deep breathing, turn them, reposition, monitor the urine output, look at the patency, strict asepsis if they're having a catheter because we don't want them to get any sort of infections. This is a surgical patient, they're at risk for infections, and pneumonia is always a problem with surgeries, and it's one of the most commonly one of the most common problems that you get post-op or in the hospital in general, so really have to watch out for that. Okay, so signs of fevers, increased heart rate, respiratory rate, adventitious breath sounds, a problem. And that's pretty much it. I'm just going to stop recording.